Psychiatric interview and mental status examination. Script and editing by G.S. Shankar, PharmD, PsyD, Professor of Clinical Sciences and Administration, School of Pharmacy, American University of Health Sciences, Signal Hill, California. Learning objectives. Learning patient interview techniques. Be familiar with the psychiatric review symptoms of 4 conditions. Define thought content and thought process and their components. Be able to conduct a mini mental status examination, or MMSE, for cognition. The psychiatric patient, unique characteristics, the patient with numerous challenges, collateral data, establishing rapport and empathy, safety considerations. Overview, key areas, introduction and identifying data, chief complaint and history of present illness, psychiatric review of symptoms, past psychiatric history, past medical and surgical history, current medications and allergies, family psychiatric history, developmental history, social history and substance use history, mental status examination, multi-axial diagnostic assessment. Introduction and identifying data. First, introduce yourself. It's important to put the patient at ease, establishing rapport right from the start. Engage in active listening and demonstrate empathy. Make sure to gather basic information like the patient's name and age. Chief complaint. In the patient's own words, ask, "What brought you in today?" Remember, this might not ultimately be the focus of treatment. Use open-ended questioning and observe the patient carefully. History of present illness. Here we elaborate on the chief complaint. Start with open-ended questions and gradually become more focused. Ask, "Why now?" Gather details about current symptoms, including their onset, duration, and chronology. Identify any precipitants and alleviators, such as treatments. Inquire about recent stressors. Use more focused questioning to narrow down the differential diagnosis. Look for pertinent positives and negatives, and emphasize any functional impairment resulting from the symptoms. Psychiatric review of symptoms. If you don't ask, they don't tell. The 4 food groups, mood disorders, anxiety disorders, psychotic disorders, and substance use disorders. Mood disorders. Screening for depression, mood, appetite, energy, concentration, sleep, self-worth, interest or motivation, and suicidal ideations. Screening for mania, increased energy, decreased need for sleep, irritability, increased activities, hedonism, racing thoughts, and speech. Anxiety disorders. Screen for both physiologic and psychological manifestations. Physiologic panic attacks, states of hyperarousal, fight or flight, psychological excess worry, fear, apprehension. Generalized anxiety disorder, obsessive-compulsive disorder. Most anxiety disorders are some combination of psychological and physiological symptoms like panic disorder and social phobia. Psychotic disorders. Screen for perceptual abnormalities, delusions and hallucinations. Screen for disordered thought processes, mainly through mental status exams and observations. Delusions are fixed false beliefs, not culturally sanctioned, such as persecution, ideas of reference, jealousy, grandiosity, hyperreligiosity, and somatic. Hallucinations include hearing, seeing, feeling, tasting, and smelling things in the absence of them. Auditory, visual, tactile, olfactory, and gustatory. Substance use disorders. Must rule out first. Assess for current use early in the interview, historical use later. How much, how often last used? Honesty is such a lonely word. Billy Joel. Past psychiatric history. Data-driven. Don't get lost in the details. Avoid excess jargon. prior diagnoses, prior treatments, medications, psychotherapy. What worked best? What side effects? Psychiatric hospitalizations. How many? For what? First, most recent. Current medications, allergies. List of all medications including over-the-counter and herbal remedies. Allergies distinguish from adverse reactions and side effects. For example, drug-induced movement disorders, common with antipsychotics, are side effects, not allergies. Family psychiatric history. It's important to ask about blood relatives, especially first-degree relatives. You should inquire about any history of mental illness, emotional problems, or whether they are on any medications for stress or anxiety. And don't forget to ask about suicide attempts and substance abuse. Developmental history. This section covers trauma and any experiences of abuse, whether physical, emotional, or sexual. The developmental history should flow naturally into the social history. Social history. Here, we assess functioning in key areas. This includes social relationships, marriage, children, and sexuality. We also look at occupational or academic history, such as the highest grade achieved, job history, and current work status. It's essential to understand the home environment, including the support network and who the person lives with. Additionally, we cover military history, legal history, experiences of domestic violence, and aspects of religion and values. Substance use history. This section requires a more in-depth coverage than the review of systems. You need to include all recreational and street drugs, herbal remedies, over-the-counter preparations, and supplements, especially caffeine and ephedra. It's important to gather details on amounts, frequency, and consequences of usage. Don't forget to ask about the most recent use. This includes alcohol, marijuana, stimulants like cocaine and amphetamines, hallucinogens such as LSD and PCP, inhalants, sedative and hypnotics like benzodiazepines and barbiturates, and opiates, among others. Mental status examination. This can be divided into two sections. First, observational data. Most areas are assessed while obtaining historical data, essentially through observation. Second, formal cognitive testing, which requires a more structured assessment using cognitive screening tools like the Mini Mental State Examination, or MMSE. MSE observational. Let's start with appearance. This includes body habitus, nourishment and age, as well as hygiene, grooming and dress. Next, behavior. Pay attention to the patient's attitude, relatedness and cooperativeness, along with psychomotor activity, abnormal movements, and eye contact. When it comes to speech, focus on the quality of production, including quality, quantity, rate, rhythm, and prosody. This provides an observable representation of internal thought processes. For mood, you need to assess the patient's internal emotional tone by asking them directly, for example, if they feel happy, angry, nervous, or fine. Affect is the observable external expression of emotional tone. Assess the range, such as expansive, full, blunted, or labile, and check for appropriateness or congruence. You might describe it in general terms, like dysphoric. Finally, thought processes refer to how ideas are put together. Normal thought processes are described as linear, logical, and goal-directed. Alright, so let's delve into the mental status examination, specifically focusing on observational aspects of thought processes. Common abnormalities you might observe include tangential thinking, where the person never quite gets to the point, and circumstantial thinking, where they think in a roundabout way but eventually get there. Then there's looseness of associations, where the connections between thoughts aren't clear to the listener, and flight of ideas, where thoughts are connected but happen so quickly that it's hard to keep up. You might also notice clanging, where the person speaks in rhymes, neologisms, where they create their own vocabulary, and derailment, where the thought process starts off linear but repeatedly shifts focus. Idiosyncratic thinking can also be observed. Now, when it comes to thought content, a normal thought process is marked by the absence of these abnormalities. However, you might encounter suicidal or homicidal ideations. Perceptions, often considered a subset of thought content, can include delusions, hallucinations, and illusions. Delusions are fixed beliefs and can take many forms, such as paranoid, grandiose, erotomaniac, and bizarre delusions. Other types include thought broadcasting, where the person believes others can hear their thoughts, and thought insertion, where they believe others are placing thoughts in their mind. Insight refers to the understanding and appreciation of one's current situation or illness. Finally, judgment is the ability to make sound decisions, which is best assessed by looking at recent history. MSE cognitive testing. This involves a formal screen for cognitive dysfunction. The MMSE, or Fullstein, is the most common tool used. Additional tasks may be added to assess frontal lobe function and parietal function, such as praxis. MMSE Fullstein. This is a 30-point screening tool. It includes orientation and various language functions like reading, writing, naming, comprehension, and repetition. It also assesses registration and recall, attention and simple calculations, and constructional praxis. The questions total 30 points. Orientation is worth 10 points, where the patient identifies time and place. Registration and recall are worth 3 points each, with patients recalling objects at 1 and 5 minutes. Attention and calculation are worth 5 points, where the patient spells a word backwards. Language is worth 9 points and tests processing language. Interpretation of mini mental state score, with a maximum of 30 points. A normal score is 24 or higher. Educational and age norms vary. For those with a 4th grade education, ages 18 to 69 have a median MMSE score of 22 to 25. Ages 70 to 79 have a median score of 21 to 22. Those over 79 have a median score of 19 to 20. For an 8th grade education, ages 18 to 69 have a median score of 26 to 27. Ages 70 to 79 have a median score of 25. Those over 79 have a median score of 23 to 25. For a high school education, ages 18 to 69 have a median score of 28 to 29. Ages 70 to 79 have a median score of 27. Those over 79 have a median score of 25 to 26. For a college education, ages 18 to 69 have a median score of 29. Ages 70 to 79 have a median score of 28. Those over 79 have a median score of 27. Any questions? Write them in the comments. Thank you for listening.